All right. Dr. Beatriz Gros is a consultant gastroenterologist specializing in inflammatory bowel disease at Reina Sofia University Hospital in Spain. In addition to her clinical role, she is an influential content creator on social media with over 16,000 followers across platforms such as X and Instagram at Dr. Beatriz Gros. She is the founder of the free educational resource IBD-EII.com, a resource offering up-to-date evidence-based content on IBD, which has attracted over 330,000 visits in just 18 months. Beatrice has been recognized as a health influencer by the World Health Organization for her work in raising awareness about IBD through social media and her website. She also works on several national and international research projects in the field of IBD and actively participates in academic discussions, webinars, and publications related to the disease. So, welcome to the podcast. So
Welcome.
excited to
Thank you
have
very
you.
much. Thank you very much for the invitation. Thank you, Ashley. Thank you, Daniel. I'm very happy to be here with you today. Um,
Yeah, we're
thank
so
you.
happy to have you. And it's so great. We've been admiring you from afar with all the work that you're doing and the website that you have, and you just won an award actually for. Tell us about the award. So I saw it was from Helio, right?
Yeah, exactly. So it was very interesting because I started the website initially thinking that no one was going to use it, or perhaps some registrars to follow what it was going on IBD. And then at some point, I saw on X that someone was saying, Bea, you should be nominated for this. And of course, I could not self nominate. So someone did. And then I was told, I received an email. I said, see, you have been nominated, and the committee decided that you are worth this awardee. And then, there was a votation, and I shared it on social media, and a lot of people, mostly on X, because on Instagram, perhaps most of the followers are patients, but on X, where there are a lot of clinicians who value what I do, they were like, well, of course we will support you. And then one day I was coming back from an on-call at hospital, and then I received a phone call, and they said, see, you won the prize. Are you coming to the States? And it was like, when? They were like next week. I was like, no, I'm not going to the States next week. I'm sorry. I have some work. And then they were like, well, okay, you have to make a video because you won the prize. And I was like, is this even real? I never imagined that this was going to happen. I thought it was not a game, but sort of, because I was like, well, people are nominating me, but did you see the candidates? Like the other people who were nominated, they had like, some people had over 1 million followers on social media. I mean, I was like, well, there's no way I can make it. But when I won, I was like, my God. So I was so surprised, and I was so excited because I never imagined that people were going to value my work so much. So it was great. I feel so happy for that.
Yeah, and
That's
well
amazing.
deserved. Well deserved too.
Thank
And
you.
for those of you who haven't been to this website yet, it's an amazing resource if you're wanting to learn about IBD. And I think so many people in the IBD space, myself included, when I was diagnosed, were just longing to learn about, what they have going on and what we know about it, and to have a resource like the one you've created is incredible. It helps so many people to have trustworthy information like that that's totally free. And I, as somebody who creates a library too, I know it's not free to create. It
Exactly.
takes a lot of money and time, and so thank you for creating that. It's just really incredible. So I'd love to know like the history with that, like what motivated you to create it, and you know who's
Yeah.
all involved. Is it just you, or do you have a team of people?
Exactly. So starting from the end, it's just me. So I'm doing this all myself, all the content, all the pictures, everything. Even I needed to, because as you said, I'm paying for this, and I don't have so much money to pay for the website. So I needed to learn. So at the beginning, I paid someone to build up the website, but all the rest, apart from the first month, I've been doing this myself. So all the checkings and so on. So I needed to learn some programming from websites. through YouTube videos, which is kind of funny, but I needed to do that because I could not invest more money and I didn't receive any funding. So I was creating all the content myself. To date, all the content 100% is been done by me. There are over 1,500 studies at the moment in there, plus all the graphs, all the infographics. So it's a lot of work. So how this started was very funny because the registrars. So I was training. I was a trainee in Spain, right? Then I became a consultant, and then 1 year after, I decided to move to the UK. But before that, when I was a trainee, because there, science is so fast, and then there are so many publications, and most of the time what happens is that you read a paper, even if it's a very good one, quite soon you forget what you read because perhaps you remember specific data, but it's most of the things you forget. So I started to study in a way in which I could check every data very fast. So I was doing a slide of each study that I was reading, not only for IBD, but even for the liver disease and for whatever thing. The thing is that when I was a trainee, I was already very interested in IBD. So most of the studies that I was reading at the time were IBD based. And especially I thought that it was going to be very easy for me to follow the trials if I was having all the trials with different slides. So the time I was going to a congress, if someone was saying, for example, the Sonic trial, if I could not recall the data, I could go to the slides on my mobile phone and check them. So I moved to the UK, and when I was there, one day, one of my colleagues saw me scrolling on my phone with my slides, and she was like, "What's that?" I was like, "Well, my slides." And she was like, "What's your slides?" I was like, "Well, I have these summaries that I made, and by that time I had 150 summaries." And she was like, "Well, this is amazing." And I was like, "Is it?" And she was like, "Bea, it's very temporal, and people sometimes forget the dimension of the time." And I was like, okay, then I treated, I made a timeline. So that was my first timeline. I treated, and then it was crazy. Like that tweet was crazy. Like in a couple of, I think it was 24 hours, it had like 50K visits. I was like, how is this even happening? I was so surprised. And then I was like, okay, I need to think about this. And by the time I continued doing my summaries, and then in Edinburgh, where I was working, there was an IBD pediatric meeting, the national one. So from people from the US, from India, from many countries were coming. And there was a talk from a pediatrician practicing in India. And I was so shocked when I heard him. So what he was saying, basically, he was sharing the story of a patient. As you know, in India, some drugs are very cheap, such tofacitinib because it's a generic, but all the drugs such infliximab, for example, are expensive, especially for kids with Crohn's disease, with perianal disease, and so on. The only one that you could use, perhaps, it's infliximab, and then it's so expensive that most families cannot afford it, or if they can, it's one dose. So he was sharing the story, a terrific story of a kid who had a lot of surgeries. The family emigrated to Australia to work there, to get some money, to pay back the bills. And then he was kind of calling the attention of what it was happening in India. And he was saying, it's not only India, it's other countries around. It's happening in Africa. It's happening in South America. That it's both the economic situation, and also there are a lot of parasites and other infections in there. And the gastroenterologists still are not very well trained sometimes on IBD because they are mostly focused on other diseases which are more prevalent. But at the same time, the incidence is rising so fast. And I was like, how can I help these guys? And he also mentioned something that really touched me. He was like, the data is so, like, there are so many things that we cannot be updated. And then I was like, well, I do have the data I summarized for these guys. And then from that day, I talked to a friend of mine. She knew how to build up a website. I was like, see, we need to make this. And then I phoned my father, because I always phone my father with these things. And I said, Dad, I have had an idea, but I'm going to invest some money and perhaps I'm losing it. And he said, see, Bea, if the only thing you lose is money, then you have lost nothing, right? So if that's the idea, you need to do it. And then that's how it started. I built the website in a month. I put all the data in there. By the time I had 200 studies summarized when I first launched it, and the rest is story. It's history.
That's incredible. 200?
Yeah, but that time, at the moment, so this month, I think we are around 450 trials summarized, plus there are over 400 studies on the multifactorial. So there is inside the website, there is a section which is IBD multifactorial, where are all the studies on, the relation between IBD and infections, or IBD and antibiotics, or genes, and so on. So in there are around 400 studies as well. And then there are the guidelines and infographics and how the disease behaves and how the drugs work. So there is a section on each of these. And every month I send an update to the people who are subscribed, or otherwise you can go inside and check the new additions.
Wow.
That's amazing.
Yeah.
Thank you.
And I really like the layout of it, Bea. Like when Ashley first told me about it, I was shocked at what I was looking at. Really, just seeing all that information in one place and seeing too your timelines of both Crohn's and colitis was really cool to see too. Ashley and I had discussions in the past about sometimes it can feel like IBD is going nowhere just as patients, or it's just like, okay, why haven't they figured this out yet? But when you see the timeline and when you go to conferences, you can really see how fast things have progressed. And yeah, as a patient, there's some reassurance in there to see that all happening. So thank you so much for creating it.
Thank you. It is in fact very impressive. Sometimes, even when I was doing this, I was learning so much, because what happens if you don't get to see all this information together is that at the end you only see the 10% of success. But there is another 90% of things that are happening around, that even if the data is negative, having negative data saying this is not associated to this, that is important too. So, for example, this drug does not work, but there are other things that are important. For example, this infection is not increasing the risk of IBD or whatever. So all these things, even if they are negative, are worth being shared. So when you say all them in context all together, it's like, wow, it's massive. The puzzle now fits better. So there are no missing pieces into this.
Yeah, it's like you're actively getting to watch knowledge build on knowledge, and you're getting to actively see that, whereas it's hard to see that when you're just looking at the one study.
Exactly. Exactly.
Yeah, that's really interesting. And you've also got, I've seen some nutrition related things on there, which is awesome, and I think people are always looking for a good resource. So definitely a great resource for people that are wanting to learn. So and
Exactly.
you mentioned so IBD EII. So what does the EII stand for? Can you explain that?
So that's the acronym of inflammatory bowel disease in Spanish, enfermedad inflamatoria intestinal. Because at the beginning, I was like, well, the website is in English, and there is a small section in Spanish, but it's mostly in English, 99%. But I'm originally Spanish, and I'm very attached to the Latin American communities, and I was like, this is the way of standing for them as well, so that I'm not, even if this is in English because the science is published in English, I stand for them, and I recognize that this is our flag. So this is not only IBD that is worldwide known, it's also EII, and I try to make it like like a connection to them, to honor my origins, if you want to say so. And some people were like, why don't you do it in Spanish? I was like, please, because I don't have the time, because I will die someday young if I continue like with so much working. Perhaps some people are doing screenshots, and then with AI you can translate or things like that, but it's difficult for me to do it into another language on my own.
Yeah. Well, your social media has a lot of that. You have a
Yes.
lot of, and that's another great place that people can go to. And I love that you have both the Spanish version and the American version, so you can really help both people. There's a lot of
Exactly.
people looking for Spanish speaking people that are looking for, I've pointed a lot of people your way that are looking for Spanish speaking resources, because there's definitely a big gap in terms of what's available there.
Exactly.
At
So the
least where
thing
I'm
is
at.
that exactly. So the website is not so the the way I write the summaries is not adapted to general population. So it's mostly focused perhaps on healthcare professionals, but there are a lot of patients who understand this data, even if it's not adapted to them into like in the vocabulary, so as to say. Um, and even though I try to down a little bit the tone so that it's more or less understandable, but it's not fully adapted. Where I found that there was a big gap was on Instagram. So before starting the website, I started the Instagram account. I used to use the hashtag IBD and look for what the conversations were around, because I had the perception that there are a lot of patients who have doubts or problems that they either don't have the time to share in the clinic, or they are embarrassed, or they don't feel secure enough to share, or I don't know, like for a number of reasons they were not discussing this in the clinic. And I was so scared of what I saw, because I found a lot of posts on people selling miracles, and that like they could cure IBD, like asking for a lot of money to desperate patients. And I was like, oh my god, I was so angry. I was like, this is not happening in front of my eyes. So that day I started my account, and at the beginning I didn't share my name because I felt a little bit embarrassed and a little bit of imposter syndrome, like what am I doing here? And I started it as at IBD-EII, the same that the website. And I was doing all the content without showing my face, just doing the summaries, just like posts and so on. And at some point, some people started to know that it was me behind the Instagram account. And they were like, Bea, people really want to hear you talk, because the way you express, I'm very enthusiastic when I talk. And they were like, the way you express the things helps building the bridge that you want to build. So when I first thought about this, was like, well, there is a miscommunication between healthcare professionals and patients, and there is a river in between. We need to build a bridge, right? So to build that bridge, you need to build trust and confidence. And if they don't see who you are, it's like, who's behind this account? And when I started sharing myself and sharing some things on my dog and my family, people were like, well, she's a human. She cries, she has very good days, very bad days, whatever. And I get to know so many people through Instagram. I love Instagram. I always say much more than X, even if I like both, but Instagram is much more creative in a way. And I got to know so many people, so many patients, so many healthcare professionals that are amazing, doing such an amazing job. Like really incredible. I could tell you hundreds of stories of people who really touched me, like they were telling me their story, and I was like, how is this even happening? This person from the other side of the world is trusting me to tell me something very intimate of her disease, and I can do nothing because I'm on the other side of the world. The only thing I can do is to listen and to show respect and to send them all the strength. And even though they want to write me, and I feel so honored of this communication. I'm very passionate of these things. So I really think this is the sort of medicine we've been trained for. So I became a doctor for this, right? This is what I really think it's doing medicine. Even if it's not my patient, or he or she is not my patient, that's doing medicine. And I can do medicine to people who are not around me, who are not in Spain, because if they write me, I always reply to every message that I receive. And that's doing medicine. That's my perception.
That's powerful. I don't know about you, Danielle, but I definitely feel like here when you see your provider, sometimes there's pressure to make it a certain time. There is that gap. There's that gap that you're
Exactly.
talking about of like, and your provider wants to be able to give you all the information and you want all the information, but there's this time crunch. And so then you walk away and there's a lot of questions and a
Yeah,
lot of education gap.
Exactly.
And that is that kind of river that you're talking about, where there's people want to know, but it's just a really hard thing to accomplish with given. But your website really fills that gap, which is really cool. Yeah.
Thank you. And I also get to learn a lot because they ask me things I never even consider myself. So I was like, well, if people are asking this, is because it's important for them. So I need to ask other colleagues if I don't know the answer. I've learned a lot because some questions that I have been asked, I don't know. Most of them I don't know because there's no data to support what this or that. So it helps me thinking like it has promoted another way of thinking. And so to my patients, every time they come to the clinic, every time we close the appointment, I always say, is there anything that you want to discuss that we have not discussed today? And if they say, no, I think everything is done, I say, okay, so for the next time, you need to make a list. Because of course, there's always a question, even if it's minor, that you have in your mind, they're around like whatever thing. Even myself, I mean, I'm a patient of other things, right? Because I don't have IBD, but I may have other things. So when I go to the specialist, sometimes because you are a little bit in a hurry, or because you feel a little bit like, oh, I'm not going to ask that. Um, you have that question inside going around, you go to Google, you look for that. No, that's not the way. I think that's the kind of communication that we need to build with patients, like to be open. We can discuss anything, sexuality, we can discuss, having kids, we can discuss mental health, we can discuss about diet. I'm not a dietitian and I'm not a psychologist and I always refer to psychology, but that does not mean I cannot talk about that. I can talk, I can listen to you, and then if I don't know what to say, I will say, I don't know how to answer to this, but there are specialists that they can, and they can help you. So, but for that, you need to ask.
It's a good reminder for patients because I feel like, in chatting with a doctor or a dietitian or any other healthcare professional, there's so much going through your mind. And I'm sure too, there's maybe, more often than not, you leave your session with that individual and then all the questions come up, right?
Exactly.
So there can just be a lot to think about, but yeah, writing it down, especially in your notes app, that's where I have like a bunch of my questions for my doctor. And pulling that out and not feeling, I guess, like embarrassed, or just knowing that there are supports out there.
Exactly. It's very interesting. It's very important.
Well, before we get into the topic that we want to talk about, I know we just talked about this for a long time, but it's fascinating to me. Before we get into that, I'd love to know from you, how did you get into IBD? Like, how did you get into kind of specializing and provide? Like, how did that happen? What interests you in IBD?
So when I was at med school, I used to work for a non-governmental organization every summer. So I spent my summers in low-income countries working in infectious diseases. Okay, so I went to Tunisia. I also work in Romania and in Lithuania, working mostly on tuberculosis and HIV. As a volunteer. And I love infectious diseases, by the way. It's something that I love and I still study about that. But the thing is that in Spain, infectious diseases is not a specialist. It's inside general medicine. It's internal medicine, right? So I was like not very convinced. And also I love rheumatology. So the fact that at some point, for whatever reason, your body starts attacking somehow the structures that are yours, that have your DNA. I was very interested on how this was happening, even if it was because there was a misunderstanding of the immune system against pathogens that are not there, and it attacks your joints, for example, or your skin for psoriasis, or your bowels for IBD, and so on. And I was very interested in that. And then my mom, she passed 10 years ago, but she ran a laboratory on IBS models with animal models of IBS, and she was expert on serotonin system in the GI tract, because serotonin is very much formed in there. So it's synthesized both in the brain and also in the GI tract. And then she started to work on models on ulcerative colitis. And then I asked for a grant to the Spanish government to work on this. And I started working with the GI department where I'm from in Zaragoza, working on this problem, where where is this misconception of the immune system happening and why? Which are the expression of the mucosa that are different to the healthy people in the mucosa, and why is this related to this or that microbiota? I was working on that for a year when I was still at med school, and in the middle of this, my mom passed. So the study never ended. So we had the data, we never published it, but it's still there. We found some, which other groups found also, some aberrant expression of an increased expression to the microbiota that is in the bowel. Okay, so for whatever reason, we know that the mucus layer is thinner, and perhaps at some point it completely disappears, and then the microbiota gets in contact to the epithelium, and then the immune system starts overreacting. This happens also in gastroenteritis. The difference is that your own immune system can stop the immune response, whereas in patients with IBD, for whatever reason, it's not able to stop this immune response. So when I was working on that, I was like, okay, this is what I want to do. So I finished my med school, and then I went into gastroenterology. And when I was training as a gastroenterologist, I was already focused on IBD. I was all the time trying to do research on IBD. And when I finally finished and I started working as a general gastroenterologist consultant, I moved to the UK to work with a team in Edinburgh, because in the UK, in Scotland, they work a lot. They have a lot of patients with IBD, and they work a lot on the role of diet and flares, and also, the mental health situation and the risk of flare. And that's why I moved there. I was working there for 3 years on this project, which I still continue working on. And then I moved back to Spain this year because my husband is here. He's a GI as well. So we've been separated for 3 years. So it was time to go back.
Oh, wow. That's a long time.
Yeah, it's a long time. So it all started with infectious diseases. I love infectious diseases. It's something I'm very interested in. And then I was also very interested in how your body starts overreacting against your structures, and why is not capable of stopping that. And then it all came as a snowball.
Yeah. Wow. So the autoimmune side of it was very interesting to you.
Exactly. It's super interesting. I'm still passionate. I read a lot about rheumatology. Like, if you see me on X, I very often share things on rheumatology and lupus and rheumatoid arthritis, because I try to read all the things that they are doing, because they are a little bit farther than we are in IBD, because they have so many drugs. They have been having these diseases with a lot of cases for many, many years, more than we do with IBD. So they have a lot of data on, combination of therapies and cardiovascular diseases and so on. So I try to read a lot on what they are doing to see how we can do that on IBD on the field.
Huh. Well, that's interesting.
Yeah, it's super interesting.
Yeah. Yeah. Well, I guess we can dive into our topic. So yeah, one of the top requested topics that we've had lately is people want to know about, what the difference. Well, what is bile acid malabsorption, for one? So bile acid malabsorption related diarrhea, that's been a topic that's come up a lot. So maybe we can start with kind of what is it, and how do we kind of tell the difference between regular diarrhea and bile acid malabsorption?
Okay, well, bile acids are substances that are, produced by the liver, okay? And they help you to digest the fat from the diet. And most of these bile acids that are produced by the liver, they go into the small bowel, they do the digestion, and then when they get to the ileum, are reabsorbed and go back to the liver, and they are somehow recycled. Okay, I'm not sure if they will be recycled, but yes, recycled. And it's just a small component of these bile acids that go to the colon. And in fact, the brown color of the stools, they come from the bile acids. Okay, if you have a bile obstruction of the bile ducts, and you don't have bile going to the bowel, your stools will look gray or white. Okay, so a percentage of these biles need to go to the colon. The problem is that in some cases, for whatever reason, and one of the reasons is having IBD, an increased amount of bile acids gets into the colon. And the colon is not ready for such amount of acids coming, and it becomes a little bit irritative, and it makes the colon releasing a little bit more of water than it normally does. And it makes the patient having a watery diarrhea that is normally very yellowish or greenish, and it's very explosive. So there is a lot of urgency. It gets worse when you eat more fat in the diet, and it makes you having a lot of urgency and this watery diarrhea that is very explosive. And why it happens in IBD? First, well, it's understandable because most of the patients with Crohn's disease, they have either an involvement of the terminal ileum where the bile acids are absorbed, and or when it's not inflamed, this area can be scared, right? Because so many inflammation in there can make the mucosa being a little bit different than normal. And then the absorption is not as good. We can see also this with vitamin B12, for example, because it's also absorbed in the ileum, and then patients with Crohn's disease can have a decreased absorption of B12 vitamin. So another situation can be that the patient has had a surgery. Okay, that does not mean only IBD. A patient who has had surgery from the small bowel, removing a segment of the ileum, can have this same situation. Also, patients receiving radiotherapy, for example, people with ovarian cancer or any cancer that is in the pelvic area that receives radiotherapy and or chemotherapy, they are at higher risk of having bile acid malabsorption. And you may ask me, well, there are some patients with ulcerative colitis that they also have bile acid malabsorption, and the small bowel is not involved. And that's true. In fact, we did a study on this a decade ago. It was one of my first studies when I was a registrar. And it's not only our data. There are a lot of studies showing that patients with ulcerative colitis, they also have more bile acid malabsorption compared to the general population. And the reasons here may be different. Perhaps it's the microbiota that lives in the ileum that is different. Perhaps it's something genetic. Perhaps these patients produce more bile than general population, because it's not only the absorption that may need to be involved. It could be that your liver produces more bile than normal, right? It could be both. For example, patients who do not have gallbladder because they have had a cholecystectomy, they have higher risk of bile acid malabsorption for the same reason, because a lot of bile acid gets to the small bowel at once. And so the numbers around, if I'm not confused, it's around 16% of patients with IBD who do not have an involvement of the small bowel can have bile acid malabsorption, which is more than the general population. And for patients with Crohn's disease involving the small bowel, it can be as high as 96, 97. So it's very, very common, right? And what comes later is the question on how can we differentiate this from a flare? Well, that's a very interesting question. So the first thing is, if it follows a logic timing, for example, a patient with Crohn's disease has had a surgery, and after the surgery, there is a continuous diarrhea, and has had a small bowel resection, that's one of the first things that you will consider. And then you could prescribe questions to see whether or not they respond. For patients who have inflammation in the small bowel, so active Crohn's disease in the small bowel, so the priority there is to treat that before this gets any worse, because otherwise the mucosa can get full of scars, and then in the future there can be a bile acid malabsorption. So in those cases, we focus on treating the inflammation as soon as possible so that the mucosa is able to recapture these bile acids. For patients who have ulcerative colitis, and this happens sometimes, as I said, it's easier to differentiate because, patients with ulcerative colitis quite often have blood in the stools, and this is not typical in bile acid malabsorption. This is just this as I said, this very yellow, greenish diarrhea that is very explosive with a lot of urgency. And that is mostly happening after eating. It's not normally waking you up in the middle of the night. It doesn't make you feel like you are losing weight or anything. It's just very uncomfortable with a lot of urgency. And in some cases, you need a colonoscopy in patients with ulcerative colitis or even Crohn's, just to make sure there is no inflammation. And then you need to do like calprotectin. Well, that's normal. Then colonoscopy. Well, that's normal. Perhaps MRI or ultrasound. It's normal. And then you get to, okay, maybe a bile acid malabsorption. So you give either sequestrants or you do a CCAT or a stool test to check the bile acids in the stools.
Bea, I feel like I was going to ask you a bunch of questions, but then you just kept covering it. So, like, that was very thorough, and definitely appreciate hearing about that. I have a question for you about Crohn's and surgery of the ileum.
Yeah.
Is there ever a point where, you get your ileum resected? Is there a point where the other part of the ileum would take on more of that absorbing power? And how long would that take what do studies show how long that will take?
That's a great question. I'm not sure exactly on the centimeters, but apparently, and this is from the top of my head, I may be wrong in the exact centimeters. If the resection is over 20 to 30 centimeters, the risk of having bile acid is quite high, especially the more you resect, the more. And if you resect like over 40, it's not impossible, but definitely it's difficult that the rest of the ileum that you have, it's able to retake all the bile acid that is produced. That said, I have seen patients with very long resections that do not have bile acid diarrhea for some reason. I promise I don't I don't get why, but it happens. And it may be the other way around. You see patients who have had very short stricture that was removed, perhaps 5 centimeters. It's very, very small, and still they have bile acid malabsorption. And in that case, I think it's the same thing that in ulcerative colitis. There are patients who, no matter what is going on in the ileum, for whatever reason, they have bile acid malabsorption. Mm-hmm. And of course, if they don't have gallbladder, the risk is higher.
Of course, yeah. Very interesting.
It's really, really interesting. And it's also very noticeable because as soon as you put the treatment, it gets better the day after. So you give it and it's very fast. So the treatment is just a sequestrant. What it makes, it just takes the bile that gets into the colon and prevents the bile to irritate the colon. It still goes in the stools. So this patient still passes the bile to the stools. It's not going to be absorbed anyway. But it does not make this irritation in the colon that provokes this diarrhea. So it's very fast. Some patients, by the way, who have very little bile acid diarrhea, but still they have some, they adapt the diet. And then when you ask, you see that they are trying to eat as little fat as possible. They make very small food ingestion rather than like proper lunch or proper breakfast. They eat very little because this way they somehow try to prevent to have all these coming at once to the small bowel, but that decreases a lot the quality of life. And I think we have treatments that we can give, and I think it's easier for them to follow a normal life or as normal as possible, and then to take the questions.
Do you see, so as a patient, if people listening are thinking, do I have that? What are like some things that would be like kind of noticeable that they can look for to say, like, to bring that back to their doctor? Like, so you mentioned yellow stool, right?
Yeah.
Anything else that's really notable?
Well, so the first thing needs to be that the patient is with normal calprotectin and normal colonoscopy - US ultrasound. So there is no active disease, right? It can happen that a patient has bile acid malabsorption and thereafter has a flare, in which case he will need both therapies, right? But generally speaking, for a diagnosis, it's very difficult to differentiate this from a flare if a patient has both. So it should be first treating the flare if it's any inflammation. And it's very typical that they have diarrhea during the day. It's not waking up in the night. It's not like the flares, like, severe flares. You normally wake up at night to open your bowels. It's normally during the day, mostly after having lunch. And whenever you eat more fat, you have much more diarrhea than if you eat, for example, a salad or something that does not have much fat on it. So that may be the thing. And also there is no blood in the stools, as said, unless it could be sometimes it's from the hemorrhoids, right? But it's not normally the case. So
So
that
would
would
you
be the thing.
Oh, sorry. Would you
No,
see more floating? Like, do you see more floating stool in those cases, like fat malabsorption as well?
yeah, it could be, but not necessarily. So that won't be the thing that will make me think of. Sometimes you can see, yes, some fat floating, but that's not the typical thing that patients come to the clinic saying. It's like, doctor, it's very typical because you see the patient who has just had a surgery or has had inflammation for some time in the ileum, or ulcerative colitis that has been in remission for long and suddenly starts having this diarrhea that is very explosive. Like, it's the sort of diarrhea, I always say, it's like an explosion. You go to the toilet and it's like boom, and it's very yellow. It's completely watery. There is normally no solid on it, and it's like this, with a lot of cramping. And once you open your bowels, you are normal back again. It's no painful once you open your bowels. It's just this a lot of motility, and boom, once it's done, it's like this. And it's normally not many times. It's not like the patient is not going 20 times per day. I mean, unless the patient has had a very, very long resection, in which case it's more a short bowel rather than a bile malabsorption itself.
You mentioned that one differentiator too is that it's not at nighttime, so it's typically in the day. Do we know why it would present? Why we would see more nighttime bowel movements with IBD flares and daytime with bowel malabsorption?
Well, I think in this case, but I may be wrong, that this is related to this happening after eating, right? So it happens normally once you have eaten. So if you have had lunch or dinner, it will happen in the next hour or two, normally. But there may be some cases in which this happens during the night. So there is in Spanish we call this organicity. I don't know if this is a word in English. So opening your bowels in the middle of the night. I mean, in the absence of course, having had big surgery. So people, for example, who have pouch, it's not uncommon that they need to open their bowels at night, or people who have had different sort of surgeries. But generally speaking, you don't open your bowels at night normally. So when you need to open your bowels at night, we call this organicity. It means that there is something organic happening. So that's very typical with IBD, microscopic colitis, celiac disease, pancreatic disorders, people who have these diseases which are really organic. So there is something organic going on there, either inflammation or either some type of deficiencies or whatever. This normally wakes you up at night. Not always, but it's generally speaking. So for example, IBS normally does not wake you up at night, to see the difference, because it's normally happening after eating, mostly during the day. It does not mean that there cannot be cases of bile malabsorption opening their bowels at night. Of course they can, especially in Spain, because we have dinner very, very late. We normally have dinner here at 9 or 10 p.m. So a lot of people go to sleep and they need to wake up a little bit sometimes. But generally speaking, if you have dinner at 7, by the time you go to bed, generally speaking, you may not need to go.
Yeah, that's so interesting about the time of day, and that being a way of detecting that. So I had a question that's kind of maybe a little off topic, but with bile acid malabsorption, what impact would you see? Do you see any impact on the microbiome? I know there are certain gut bacteria that like to eat bile, right?
Yeah.
Would that cause them to grow in population, or like what kind of impacts do we see with that, the microbiome?
There have been a number of studies that showed both. So first, for patients who do not have IBD and have bile acid malabsorption for whatever reason, they have different microbiota in the terminal ileum and in the colon, both. It can be the consequence. it's difficult to know whether it's the consequence of the bile getting to the colon that is getting these changes in the microbiota, or is it the microbiota that changed all this. It's difficult because we are not completely sure on why there are patients who do not have, like, they have their bile rather in situ, they have no bowel issues like themselves, but still they have bile acid malabsorption. It's hypothesized that this happens because they produce more bile. Well, it could be, right? But still, we don't really know, because measuring how much bile one person produces is very difficult, because most of it will be reabsorbed. So it's difficult to do that. That being said, so you have this, and then and the patient has had this, and you analyze the microbiota having IBD, for example, with no bile acid malabsorption. Well, patients with IBD, we know the microbiota is different compared to the health population. So again, if we analyze the microbiota, I'm not completely sure. I cannot recall having read any study showing the difference in the microbiota of patients who have IBD plus bile acid malabsorption and those who do not. But it makes all the sense, because most of the patients who have bile acid malabsorption with IBD have had a surgery. And we know patients who have had a surgery, the microbiota changes, especially because normally they remove the ileocecal valve that connects the colon with the small bowel. And this valve separates the colon from the small bowel. But if there is no valve anymore, the bacteria can go from here to there. That's the same reason why patients with IBD are at a higher risk of having SIBO, because there is this valve makes the bacteria go in there and they can overgrow somehow. So it may be necessary to check. I have not checked myself whether the microbiota is the same in these patients in different parts of the colon and in different parts of the ileum. Also, we need to bear in mind that when we analyze the microbiota in the stools, this does not necessarily mean the microbiota close to the biofilm in the mucosa. So there are the microbiota living in the stools, and there's another group of microbiota that not necessarily is the same from the one in the stools, that is in the mucus. So the mucus layer in the colon has two layers. So it's a mucus and has two layers. And in this one, the external one, there are some microbiota living there, and these are the ones that are in contact with the immune system. For the small bowel, the mucus layer has only one layer rather than two, because in the small bowel, there's not supposed to be so much microbiota as in the stools from the colon. So normally the microbiota, the big amount of the microbiota lives in the colon rather than in the small bowel.
That's interesting. With the mucus layers, so this might be an oversimplification, but I was reading about there being some mucus loving gut bacteria. So
Exactly.
if they don't have enough fuel sources, that they will then consume
The
more of the
mucus.
mucus layer.
Exactly.
Right?
That's exactly like that. In fact, one of the reasons that patients with IBD have a different mucus thickness compared to general population, there are a number of hypotheses. We know that there are some genes associated to a decreased secretion of the mucus in patients with IBD. Second, there are these microbiota that are able to eat this mucus, and on the other hand, there are mucus bacteria. So there are bacteria that are able to help to produce more mucus. So these are the anti-inflammatory, inverted commas, ones that help protect the mucus layer, whereas there are others that they do the other way around. They are inflammatory and they get to consume it. And also there are, in the mucus layer, there are cells that are the ones that produce the mucus. So not all the cells in the mucus, in the epithelium, are able to synthesize the mucus. It's specific ones, and some of these cells may be deficient or may have these genes that I mentioned that make the mucus not being as protective, perhaps, as the general population. Or it may be all together. Sometimes it can be all together.
Yeah, so a lot of factors at play then.
Yeah,
What
exactly.
are you mentioned there's some gut bacteria that create more mucus. Like, do you know any of the names or like classes that?
Exactly. So, well, the ones that we know that are more anti-inflammatory is the one that have been shared, in every congress. Is Fecalibacterium prausnitzii is one of the bacteria that we know has an anti-inflammatory role, and it makes these short chain fatty acids that they have these anti-inflammatory properties, and they promote the secretion of more mucus, right, by these cells. And there are some others, but again, it's very difficult to analyze because we need to analyze the bacteria in the mucus to know which are the ones promoting this rather than the ones in the stools. For example, from the ones that disrupt the mucus, Clostridium difficile infection, Campylobacter jejuni, disturbs the microbiota and the mucus layer, and some other infections, salmonella. These infections sometimes do not behave like infections themselves because they can live inside the colon as normal microbiota. So as to say, for example, Clostridium, the Clostridium difficile, it's a family, and they can live in the colon not being toxigenic. So the infection of Clostridium that we know, it's toxigenic Clostridium difficile. It's a bacteria that starts producing toxins. But if the bacteria is not producing toxins, it's supposed to be just a commensal from the normal microbiota. And a lot of healthy people have Clostridium in their feces because it's just randomly found there in there.
I didn't know that. So we're talking about C. diff here, which is like a scary
Yeah,
thing for people, if you've ever had it. But I did not know that there was like an okay C. diff, and the difference is just like what's being produced by that gut bacteria.
exactly. So by the way, in our hospital, and I guess it's in most of the hospitals, we do two stool tests when we need to check for C. diff. The first one checks whether or not there is C. diff in the stools, and it says yes or no. And once it says yes or no, then we check for the toxins. It produces toxin A or toxin B or both. And then we check for these three. If this is negative, it's just a commensal Clostridium that is in there. It needs to produce the toxin to make this Clostridium difficile infection. Otherwise, it's not an infection. It's just there.
Wow.
It's
Oh,
it's
interesting.
yeah, it's very interesting.
Yeah, and I was also learning too that there are some, I guess there's oxygen loving gut bacteria and oxygen ones that don't like, and so the oxygen's being produced by the mucosal layer is, and
Exactly.
so then your more helpful gut bacteria can coexist in that area, and the ones that we don't want to be there kind of the mucosal layer plays that role of protection from that sense too, right? Is that the way to explain it, or how
Yeah.
would you explain
So not only in the gut, but we have bacteria that live with oxygen, so they need oxygen to survive. Then others that do not, they are anaerobic, so they do not consume oxygen, and some others that can use oxygen or not, depending on the situation, right? And we find these three in the bowel, this type, and they are combined. And some ones are more producing oxygen, some others do not and consume it. And finally, the balance, I'm not completely sure we understand completely at the moment how these different three types of bacteria behave, and whether or not they are related to the inflammation. They may be, especially for the ones that are able to be anaerobic or not. These ones that change from one time to another one, these may be the ones that are more interesting to analyze. But I don't have much expertise on this. So I know they are, but I'm not completely sure we understand perfectly what is going on there with IBD in relation.
Yeah, so much of things are still a mystery, even though we know
Yes,
a
exactly.
lot.
Yeah, it's very complex. Actually, it's like a universe. It's like having a universe inside.
Yeah, isn't there a lot of quotes about that too, about how um there's more, I've heard like different things, there's more gut bacteria inside of us than like
Like
stars in the
cells.
universe or something like, or yeah, and
Exactly.
cells in our body. It's, yeah, it's uncharted territory,
It's
which is
it's
I
so
think what
interesting.
fascinates me the most. Yeah.
Exactly. It's super interesting. And we are talking only about the gut, but we also have so many bacteria in our mouth. And we know patients with IBD, they get a lot of mouth ulcers quite often. and this colitis here in the lips, and all this. It's very interesting, and we know there is an increased risk of mouth problems in patients with IBD compared to the general population. And of course, the microbiota in patients with IBD in the mouth is different than patients who do not have IBD. Even if they don't have mouth ulcers, the microbiota is different. Especially in kids, there are a lot of studies on this because kids get to have a lot of periodontitis and mouth ulcers, aphthous stomatitis, and most of the studies have been focused on the kids. But I have a lot of adults. I always ask, do you have mouth ulcers that come very frequent? And when you ask, you get a lot of patients who have mouth ulcers.
Oh, yeah. Mouth ulcers are the worst.
Exactly. Especially, it can be also due to the deficiency of some vitamins.
Mhm.
So we need to check. But also, it can be just part of the disease as an extraintestinal manifestation.
Yeah, that part is so interesting to me. Would you say you can get extraintestinal manifestations even when you're in remission, or do you more commonly see them in flare-ups?
So, by definition, they can happen at any time. But normally we see them parallel to flares. These are the more frequent ones. So the mouth ulcers, the erythema nodosum, the arthritis. But there are some others who are not parallel to the flares, such as primary sclerosing cholangitis or axial spondyloarthritis or pyoderma gangrenosum. So sometimes it's difficult to know, but we always forget. I always say the fact that we call them extraintestinal manifestations, they are extraintestinal manifestations, but we forget that IBD is not it's not a disease from the bowel. It's a systemic disease because we can check it from the blood and you can find it in the blood. You can see the markers in the blood. So it's all over the body. It's just that it has some signals all around in your joints or in your skin or in your lungs, wherever it is. And yes, it's super interesting, and it's one of the things that intrigues me a lot, the role of the extraintestinal manifestations on how the disease progresses and behaves. Because there are a lot of patients who are very well controlled, and for whatever reason, they have something new. And it's like, why is this happening? And of course, the microbiota there may have a very important role, but it's like, why is this just happening now? Why is the joint inflamed? Or why is this patient having these eye problems now? Because the disease is good. And well, we forget that we sometimes need to see the patient as a whole. Patient is not a bowel. It's just a human with a systemic disease that can have a lot of things around.
That's a really good reminder because it's hard to imagine too. It's like, how could my bowel and psoriasis and arthritis all be connected, you know? but
Exactly.
but you can have like psoriatic arthritis and related to the IBD.
Exactly. It's super interesting. So the immune system to me, it's something that I'm not an immunologist, but I wish I could know more and more because it's really intriguing to understand all this, and it's very complex. I make a big effort to understand every paper that I read on this because it's so complex to understand how the immune cells communicate and how they send this or this message to start the inflammatory cascade.
Yeah, wow. Well, this has been a really fun conversation, and I hope we can have you on again, and maybe we'll talk
Yeah,
about
sure.
extraintestinal stuff. That's another hot topic. But thank you so much for coming on, but also just for your work and passion in the IBD space. It means a lot, not just to people that have IBD, but to me too, to know that people care and to know that there are people out there that are just as interested as I am about the topic and just as interested in helping people with IBD. So thank you from me as a
Th-
patient too for what you do.
Thank you. Thank you to you because you also do a great work on social media and with this podcast. So it's super interesting that you are helping other patients to better understand their disease and support them. So congratulations as well.
Well, so where can people find you if they want to get connected? So we know your website, ibd-eii.com. Where else do you prefer people to get?
I can be very easily found on Instagram at dr.beatrizgros. And on X, I am Bea Loque Bea, which is it's difficult to say when you are not a Spanish speaker. So perhaps I can tag it or text
We'll
it
put it
somewhere.
yeah.
Exactly, because it's difficult. It's a game of words in Spanish, because Bea in Spanish means to see with V rather than B. So it's like a joke saying "see what I see" somehow.
Oh,
Oh,
So it's a
I like
game.
that.
It's a game of words. Yeah, exactly.
clever.
I like that. All right. Thanks for being here, and we'll
Thank
talk to you
you.
soon.
Thank you. Thank you very much for the invitation. Have a very nice weekend.
Thank
You.
you.